Well, good day and welcome everyone. I'm Dr. Edwin Shalbois. I'm director of the NIMHD UCSF Research Coordinating Center to reduce disparities in multiple chronic diseases. The Coordinating Center supports NIMHD's initiative of 11 research centers focusing on understanding, intervening, and impacting on health disparities in multiple chronic diseases and their common pathways. Now I'd like to turn it over to Dr. Mandana Khalili, the director of the Coordinating Center's Investigator Skills Development Unit. Mandana is a professor of medicine and physician scientist at UCSF with a long history of disparities research in viral hepatitis and other chronic liver diseases. Mandana.
Thank you very much, Dr. Shalbois. Welcome, everyone. On behalf of the Investigator Skills Unit, I'd like to welcome you to this educational seminars of many to come to help to address disparities for investigators and their partners. Before we start this session, I'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Great, okay. So first, I'd like to thank our unit manager, Ms. Rochelle Blanco, whose efforts has been instrumental in organizing this session. I'd like to now introduce our panelists. We are honored to have the presence of two of our esteemed colleagues for this presentation. We'll start the session with Dr. Alicia Fernandez. She's a professor and associate dean of population health and health equity in medicine at UCSF and a general internist at Zuckerberg San Francisco General Hospital. She's also the founding director of the UCSF Latinx Center of Excellence in RSA and UCSF funded initiative to increase academic diversity. Dr. Fernandez also directs the Latinx and Immigrant Health Research Program at the UCSF Center for Vulnerable Populations. Her research expertise includes language and literacy barrier in healthcare, healthcare equity in chronic disease, and racism in medicine. She's served on the National Academy of Science Roundtable on Health Literacy since 2014. She's also on the board of governors and chair of the Science Oversight Committee at the Patient-Centered Outcomes Research Center. And she's been serving on the board of directors of the American Board of Internal Medicine since 2020. Next, we'll have Dr. Paula Braveman. She is the professor of family community medicine and director of the Center for Health Equity at UCSF. For the past 25 years, she's studied and published extensively on health equity and the social determinants of health. She's working to bring attention to these issues in the US and internationally. Her research is focused on measuring, documenting, understanding, and addressing socioeconomic and racial and ethnic disparities, particularly in maternal and infant health. She's been a research director for a national commission on the social determinants of health in the US, supported by the Robert Wood Johnson Foundation, and she's been elected to the Institute of Medicine in 2020 and has served on the advisory council of the NIMHD of the NIH. Our session will be moderated by Dr. Stuart Gansky. Dr. Gansky is a professor and Lee Hyson Chair of Oral Epidemiology and Associate Dean for Research in the School of Dentistry at UCSF. He's been working on health research for over 30 years, and his interests are in oral health, health disparities, community intervention, prevention trial, tobacco regulatory science, and related methodologic issues. He's served on numerous NIH data safety monitoring boards and special emphasis panel. In addition, he's directed the Data Coordinating Center for several NIH-sponsored early childhood caries collaborative centers and also Oral Health Disparities and Children Consortium. He currently serves as one of our co-PIs on the Research Coordinating Center grant for the multiple chronic liver diseases. Without further ado, I'll pass on the floor to Dr. Fernandez. Dr. Fernandez.
Thank you very much, Mandana. Appreciate you inviting us to be here. Hi, everyone. I want to keep this as informal as we can with a lot of people. as Mandana mentioned, I'm Alicia Fernandez. My own research is in diabetes, primarily on language barriers. And I had the good fortune of co-chairing the PhenX Social Determinants of Health working group, along with Dr. Barbara Entwistle. There were, I think, 10 other folks in that working group, along them, my wonderful colleague, Paula Braveman. And so what I thought I would do now is just tell you a little bit about my understanding of of what our task was and the rationale behind it. And then Dr. Braveman can help us get a little bit more into more of the details. So why do this? Why PhenX? And my understanding of this is that NIH did extraordinarily well with the PROMIS measures. And many of you are familiar with the PROMIS measures. Those are patient-reported outcomes measurement information system, which is a way for patient, it is a series of measures that investigators can use to measure patient-reported outcomes. So we're measuring pain. There is now a PROMIS measure for pain. And so that way, whether you're working in cancer or in diabetes or in anxiety, and you wish to measure pain, you can use this measure, know that it has some validity behind it. And most importantly, by using standardized measures, groups can compare results more easily across studies, or if necessary, combine studies using the similar measures. So my understanding of this is that NIMHD in particular, the PhenX measures include lots of patient-reported and other measures, but NIMHD in particular wanted to make sure that there was a toolkit for investigators to peruse and use that hit on the social determinants of health. So when we started working on this, and maybe what I'll do is just share my screen here. When I hope people can see this. I somehow have not quite mastered Zoom in all of this time. Can people see this?
That's
yeah,
perfect.
great.
That looks great.
So the social determinants of health, we thought about them as a core collection, as an individual collection, and as a structural or non-individual collection, community-based or population-based collection. And what you will see here is that there were some measures, and I want to come back to this, some measures that we were told no need to look at these because these are already in PhenX or being addressed by some other group in PhenX. Most notably, the measure for ethnicity and race, and that's what I want to come back to. And then here are some measures, the shaded measures indicates the ones that we identified as also being of importance to include. Similarly, in the excuse me, in the specialty collection and in this structural collection. And again, the thought here was not necessarily to find the best measures. It was to find a measure, particularly for people who were not working in that area, but people who wanted this as an important thing to measure, perhaps as a confounder, perhaps as something on the mediating pathway, perhaps as an explanatory variable, but not necessarily their main outcome measure. And they were chosen as much as being for ease of use across multiple studies as they were for the data or evidence base behind that measure. So we figured out these were the measures we wanted to include. We then divvied them up. We put them out there to the research community and said, guys, what do you think of these measures? And you've all been recipients of these. And is there anything important that is missing? And what I recall that came back, and Paula, you should correct me if I'm wrong, is that the one measure that we had not included, that people thought was important to include, was spirituality. Consequently, that was included and added to the individual measures list. So what happens then is that, and I'll stop sharing, is that that you can go into the PhenX website, you can download these measures, you can agree as a group, particularly now, I mean, obviously you now have an infrastructure with the coordinating center, and I don't know what process you will have to agree on which measures you will be using. I only want to call your attention to one thing, which I think might be important. And that has to do with an area. So for many of these measures, I, of course, am not an expert. My work is in language and so on. But there is one area where I do want to call your attention to it, adding my 2 cents of expertise. And that has to do with a measure that for sure you will use, and that is on race ethnicity. And as I mentioned, this measure was not examined by our working group. And so when we look at the PhenX toolkit for race ethnicity, we find 2 different measures. One of them is under the individual, and we find that it gives the census categories, where people, the first question is, are you Hispanic? Yes, no. And then the next question is, what race are you? I will urge you to please not use that measure. There is ample evidence showing that that measure does not work in the largest population group in the United States, minority population group in the United States. And for 3 extra points, people can guess what that group is, and that is Latinos. And it is known to not work in Latinos who switch races with dramatic swings in between census, 20 points of percentage changes, 15 points of percentage changes. Instead, I would urge you to use another measure. If you want to use the race ethnicity measure from the PhenX, I would urge you to use the other race ethnicity measure that is in here, and it is in the section under population-based measures, whereby Hispanic/Latino is one choice among other choices. So you can decide, you can check that, or someone can check that box and then not be forced into the race category, which is the category that is so unstable. Happy to take questions about that later if that's what people want. So that's what I can say. And let me turn it over to Paula, and then perhaps if people are interested in different parts of this, we can talk as a group. Dr. Braveman.
Paula, you're mute.
There, is that better?
Yes, perfect.
Yes, thank you. Sorry about that. That was great, Alicia. And I might want to add, in terms of background, that there was a big emphasis, at least, and please correct me, Alicia, if I'm wrong, at least in our working group, the big emphasis on measures that had been validated, measures that had been.
Absolutely right. These weren't the experts' best take on the measures. This was the literature validation, and again, ease of use. Thank you, Paula.
Yeah, and that posed difficult questions at times, I think, for the work group between measures that had been validated, but which we knew as investigators ourselves could be difficult for other researchers to incorporate into their research because they were so long. We knew of measures, more brief measures that, had seemed to work in a study or two. But that wasn't going to cut the mustard in terms of the standards for the working group. And I know I felt that there was a tension there all of the time. Next slide, please. Alicia has just shown this to you. This is just a sampling of some of the measures. I think it's great that a differentiation was made between measures at the individual level and then measures that need to be measured at the population level because they are structural measures. So next slide, please. So now I'm just going to show you a few examples just to give some concrete examples. Although I think the concrete example about race ethnicity that Alicia described is a very important one. But here, as an example, annual family income. So I probably don't have to tell most of you why it is that you would measure income in a study, but I would like to remind you that both income and wealth has a separate measure, by the way, of wealth as accumulated wealth, but both income and wealth, they represent resources that can be used to buy goods, to buy services, to buy power, and to buy prestige. And when we incorporate these variables and racial ethnic variables and other variables in our models, we ought to be thinking conceptually about, what is it that this represents and what's the relevance, to what I'm studying, rather than a sort of a knee-jerk approach. So the PhenX measure for annual family income, I think, is a quite good one. And it asks about total income for the last calendar year before taxes, explicitly includes the income of all family members. It starts with an open-ended question. And then if the person refuses, then instructs the measurer to ask, was your total family income from all sources less than X or less than Y, et cetera. And all of these, this measure actually came from the panel survey of income dynamics at the University of Michigan, which was time tested over the decades, plenty of validation. The next slide, please. So this is, the font is too small to get a whole lot out of it, but I just wanted to show you this with the whole worksheet for the income question, just as an example, so that then for each one of the measures, there is a very detailed data collection worksheet that walks you through exactly how the measure should be collected. Okay, so the next slide, please. This is just the rest of the data collection worksheet for the income question. Another example that I wanted to highlight for you is educational attainment. Education represents skills, it represents credentials, it represents prestige, and we know it can affect health in many, many different ways. Education, for those of us who weren't born into fabulous inherited wealth, education is the biggest determinant of the kind of job we're going to get and the kind of income that we're going to earn. But education also, we have ample literature showing that education affects health through pathways involving health literacy, coping skills, and then also ample literature showing that education affects health through affecting power beliefs. For example, sense of control. And all of this, this literature was considered important for documentation in the work of the work group. So the education question is simpler than the income question, happily. What is the highest grade or level of school you've completed, or the highest degree that you've received? And then the interviewer shows, if you're face-to-face, shows a card showing different levels or degrees. And obviously this needs to be adapted to different situations, whether it's an interviewer or whether it's a written survey that someone's completed, and whether it's a telephone interview. But there's guidance. There's very, very specific guidance given in the PhenX protocols for each one of those situations. So it's really a great resource if you're looking for, you're looking for a measure that has been amply validated and that has been dissected and gone after by experts from multiple disciplines, whose rationale has been approved, and then where then the actual details, the mechanics of collecting it are specified. The PhenX Toolkit is really a great resource. So this shows what would be on a hand card or on a written survey for the education question. Okay. Next slide, please. And this is my final example. Another one of the individual level measures in the PhenX social determinants toolkit is one to measure food insecurity. And there, what is used is a very, very amply validated measure from the USDA. It's a 6-item standard measure from the Economic Research Service of the USDA. And it asks questions like the food that I or we bought just didn't last, and I or we didn't have enough money to get more, and then follows that up with the question, was that often, sometimes, or never true for you or your household in the last 12 months? part of that 6-item standard measure also asks about whether you could afford to eat balanced meals and whether that was often, sometimes, or never. And then a question about, in the last 12 months, did you or other adults in your household have to cut the size of your meals or skip meals because there wasn't enough money for food? And now I will make a confession before I close my part of this, which is that I for quite some time have collaborated with the California Department of Public Health, the Maternal and Child Health Division, to run an annual postpartum survey. So it's a survey of maternal and infant health. For years, we had the 6-item USDA measure on the survey, because that really has been the gold standard. Recently, being squeezed, for wanting to put other measures on the survey, there's been consideration of using possibly a 2-item measure that has not been as extensively validated, but has had some validation and looks pretty good. And it's a painful decision to be made. And I know you will all be in that, face that painful decision, especially when you come to, I'm not going to show you more about the wealth measure, but measuring wealth really requires a number of questions. That can't be done, even in a 6-item question. And so there'll be this temptation to go with a less validated measure, not use the one from the toolkit. But what would be the pity there, I think, is the incredible opportunity that you have to be able, potentially to pool data across centers. That is just, it's not been done before, and it won't be done if everybody's using their own favorite measure, even if their favorite measure, has some support for it. So, so in closing, I see this toolkit as as really quite a, as quite a resource, quite a unique resource that can, it can open up some possibilities for you that investigators previously haven't had. If you will use the standard measure from the PhenX Toolkit, and I will close with that.
Great. Well, thank you both, Dr. Fernandez and Dr. Braveman, for providing us with an overview of the process for the PhenX Toolkit on social determinants of health, and actually that there are 3 collections in the toolkit. I did put a link to the toolkit in the chat, and thank you for providing some details on a few of the items that make up the toolkit, the core collection. So I'd like to start using the moderator's prerogative. I'd like to start knowing some questions that we've already heard in the last couple of months from the centers themselves. Some of them have suggested using other collections, other toolkits, such as the one from the Centers for Medicaid and Medicare Services, Accountable Health Communities, Health-Related Social Needs Screener, the All of Us initiative, which has been developing a social determinants of health toolkit or core. So I wondered if we could take a step back, and you've mentioned that a little bit about your process. You talked a little bit about only considering validated instruments. And I wonder if you could tell us a little bit about the composition of the working group that Dr. Fernandez co-chaired and that Dr. Braveman was part of, a little bit more about the composition and the process in which you used to identify these particular items.
Sure. I can show you a list of the folks. Can people see this list? Mandana, can people see this list?
Yes, we can see the list.
Thank you. I can see you, so that's why I was asking. So as we said, Barbara Entwistle and I co-chaired. Paula Braveman, you've just met. William Darity from Duke, Patrick Remington from Madison, Consuelo Wilkins, who I think is probably well known to many on the call, from Vanderbilt, Teresa Cullen from Indianapolis, Mark Fawcett, and Melly Twali from Honolulu. And the process, and then we were assisted, there were people from NIH there, and then we were assisted and really beautifully supported by a group from RTI International under contract to NIH. This group was put together, the working group members were put together by NIMHD, and they chose it, I believe, to represent a range of types of researchers. And in particular, I think from my understanding of those discussions is that it was important to have clinician investigators like me, as well as PhDs who may have, speaking in broad terms, more rigor to their studies. It was also important to be able to represent a community of clinician investigators where people may be like, I don't really know about these things. I know it's important. I know we should measure it. How can I find something to measure? And in terms of the process, after this discussion, which was in fact very interesting about, and as Paula mentioned, about making sure that we wanted to measure both individual level and population level things, and then discussions about what could and should, really should be included. The measures were split up among the members of the group, with people who had more expertise or interest in one area or another going to them. And then those folks came back and presented their recommendations, and the group usually adopted those as if the measures were in fact shown to have been validated and were not too and seemed reasonable in the sense that they were concise enough. Though, as Paula mentions, it's very difficult to measure wealth concisely. And I do think that there may be, depending again on what you're studying and how important it is to get a measure, and particularly for those of you working within this great NIMHD collaboration, it is reasonable to substitute, very reasonable to substitute other measures as long as you agree. I also think that in terms of like, well, why should we use these measures? CMS has some, or from all of us has some, and many of you know that there are people who've been doing lots of work. Certainly our colleague Laura Gottlieb here at UCSF, people are doing lots of work to say, well, what are some measures on the individual level that are short enough that can be asked and put into, for example, the electronic medical record. I think it is reasonable to, again, no one is holding out that these are the best measures. It's simply, these are useful measures. I hope that helps. And I think, again, I want to reinforce a little bit what Paula said. For example, in my own area of interest, in limited English proficiency, we recommend the use of the census measure. How well do you speak English? Very well, well, poor, or none. Not a great measure. So why do we recommend it? Because there is a long literature that is based on that measure. Because using that measure is in the census. You can get, you will have that same measure if you wish to look at what proportion of the community is not English proficient, and so on and so forth. So I think that these are reasonable. The idea here was to make reasonable choices and reasonable compromises. Stuart, does that get at a little bit of what you were asking?
Yeah, thank you very much. I think that's really helpful.
And maybe,
we are getting...
Stuart, well, and maybe I can just add that I would say I absolutely agree with what presented. I would characterize the working group as heavy on the social science.
Yeah, I had to play the, I'm just a doctor. Give me the answer. What do I use here? I see some really great questions in the chat. So and of course I see that Dr. Tana has her hand. But Stuart, you're going to do the honors, right? And
Stuart's going to be moderating the question.
Yes, I'm gonna attempt to get. Hopefully, we'll have time for every question. So let's go with Dr. Tana, who has her hand raised. I want to reward using that function. So please go ahead.
Thank you so much. I just was wondering if, Alicia, you could repeat what you said about when you think it would be okay to substitute other measures. You said, like, if the investigator thinks, and I missed that part.
Yeah, I think it depends a little bit. So, for example, this group, many of the people on this call are expressly interested in disparities, right? So you're expressly interested, most likely you will be doing much of your research with poorer populations, right? So you might wish to make the wealth question the single most important measure of wealth in the US. I am not an expert in this area, but do you rent or do you pay a mortgage, right? Bingo, you're done. That is something that all of you it's reasonable for all of you to decide on that, right? Or you may decide, you know what, we work with a population that is so poor that measuring wealth just isn't that important. And that is a reasonable choice. So that's very different than, say, someone who is working, I don't know, in a disease state. They're looking at breast cancer and they want to know, is chemotherapy A better than chemotherapy B? And they have decided that one of the important measures is wealth. And that makes sense because they want to get us income we know doesn't work well in the elderly because it's not an accurate reflection of the resources at people's disposal, right? So for those folks, they're doing a large breast cancer study. For those folks, it may be very reasonable to say, we actually want to know how wealth works, and we're going to take the time and the real estate space in our survey to actually ask about wealth, and we need to ask it in a more nuanced way because people may have all sorts of degrees of wealth. Does that help sort of clarify what I was thinking, Michelle?
Yes, that's super helpful. Thank you so much.
Okay, so we are getting a lot of questions in the chat now, so hopefully we can get answers to all of them.
Yeah, I want to definitely talk about the question on documentation.
Yeah, so that one just came in. Before that, I was going to ask about the question of ethnicity and why is it only Hispanic or Latino or non-Hispanic, non-Latino when there are obviously many ethnic groups in the
political history of that. Yeah.
So what I was saying at the beginning is that the one measure that we were explicitly told not to discuss was race ethnicity. And perhaps that's why I feel so comfortable criticizing it, because I'm not criticizing myself or my colleagues. But that was one that we were explicitly told was being debated elsewhere. But again, if you were to ask those folks, I think that they would say, again, you're looking at these things more to measure not the exposure and not the outcome, but other forms of confounding or mechanistic variables. And you want to be able to, at some point, benchmark what you're doing versus other ways that people have done it.
Right. So I'll just add, thank you. I'll also add that in some of the disparity centers that we've worked with before, basically we start with the Office of Management and Budget requirements because we're all required to report our enrollment data according to those characteristics. But that is the floor, that is not the ceiling. And then we have, we have asked about ethnicity, we have asked if someone says, yes, I am Hispanic, Latino, or Latina, then we ask, what ethnicity, because things are different for people of Mexican origin or Central American origin or South American origin. And so, we ask for more detail, but then we can roll up to a less detailed level to report it if for any kind of reporting or analysis. So I would think that it's, it's the floor, not the ceiling. And then I'll also sort of talk just for a second about the role of this consortium in the role of our Common Data Element Working Group and Data Harmonization Working Group is to come up with consensus for the 11 centers of how we are going to collect this data, and that we will at a minimum collect that. It's the core common elements. And of course, every study is going to tailor the other questions and other instruments to meet the needs of their studies. So again, it's a floor, not a ceiling. And so I'll move on to another question, which is, could you please explain differences between measures or tools used for research versus measures for clinical practice?
I'll just tell you what I know, and I'll defer to Paula and other folks, which is that measures used for clinical practice tend to be ultra brief measures, and clinical practice prizes brevity even more than researchers do, and it's also highly important, actually, in both research and in clinical practice, not to offend and to have those measures be better. So, for example, again, in the area I do know something about, we typically ask people, what is your preferred language in healthcare? Now, we know that about 20% of Chinese speakers who also speak English very well will say Chinese, a Chinese language rather than English. And we know that roughly about the same numbers do that who are Spanish speakers and yet speak English very well. We also know that there is no literature showing disparities on patients' preferred language, or let me put it this way, a limited literature. And that measure is less precise. And because it is less precise, it tends to push toward the null, obscuring disparity. But no one wants to have the person at the front desk say, how well do you speak English? Very well, well, poor, or none. People don't want to say that. And because it runs the risk of offending people without suitable training. So most places are using, instead of the census question, they're using, what is your preferred language? And then they say, do you want an interpreter or do you need an interpreter? And unfortunately, we know that question is also poor because people will say no, right? Because they brought their interpreter with them, right? So these are problems that reflect a difference of asking questions in clinical care and asking questions in research. Does that make sense? And I hope I answered that correctly. I hope I explained that well. What we're trying to do then in studies using EMR is to say, okay, we're going to say, what is your preferred language and non-English, and saying, yes, I need an interpreter, and at least define that group as being cleaner of being a limited English proficiency.
Yeah, I think that there's an acceptance that the clinical measures are screeners, function more as screeners.
Okay, thanks. So another question we have, which I think is the one that Alicia, that you were speaking about, is why wasn't immigration legal status included, or is it, in the PhenX toolkit?
Yeah, great question. So there's two reasons for this. One is, please keep in mind when we met, which was under the last administration, and the worries about whether or not this should be included willy-nilly, and whether or not how protected these questions were, and so on. My advice for those of you who do studies like I do, where documentation study status is very important, is to use the question from CHIS, from the California Health Interview Survey. And what that question does is that it asks about, are you a citizen? Do you have legal residency? Do you have this type of visa, or that type of visa, or that type of visa? And does it, or and then there is a anything else type box that people can check. And what it turns out is that if you don't have one of those others, the overlap with the undocumented pool is very good. And in fact, we know that because the CHIS estimates of undocumented folks match really nicely with other measures of undocumentation. So you're getting a measure by exclusion, you know, you're not a citizen, you're not a permanent resident, you're not here on such and such, these other two large visa categories. It's close enough to say that you are either undocumented or in a tenuous immigration status. Of course, if you're doing certain types of studies, your work is on the Salvadoran population, your work is on the Haitian population, then of course you may need to tweak that sometime because of a particular TSP status and other status that people may have related to that. But if you're working in that area, you know this.
Thank you for those recommendations. I think that will be really helpful for some of those studies. I'd like to come back to actually the very first question and expand it a bit. The very first question was, do you know to what extent this PhenX toolkit on SDOH measures has been used on Zoom or on a Casey or on other sort of technologies rather than face-to-face interviewing?
I think it really depends on the measure. And you'll if you go into the PhenX toolkit and you click on a measure, then it explains how to use it, and it gives at least one, often more, references about that measure. And you can read on that and see whether or not it has been used. Unfortunately, one of the things, again, as someone who studies non-English speakers, one of the things that we tried to point out where we knew there was validated, where the measure had been validated for use in either Spanish or in written Chinese or some other language. But many of the measures have not been validated in non-English speaking populations. And I saw that my esteemed colleague, Aditya Karamanchi, wanted to know to what extent these measures have been used outside of the United States. I think you have to go measure by measure and see what you are looking at. And of course, as I know you know, one would have to be very careful in applying these measures outside of the United States, because so many of these concepts are inherent within the social context of the United States, such as the whole definition of race or wealth or other measures.
And that was very much the charge to come up with measures for the US that might or might not be more widely applicable. And I'll just toss in another observation at this point. I felt that there was nothing arbitrary about the process that was used. I really felt that what the working group came up with was not, sort of the pet measures of any, of any particular person, much as some of us would have loved to have had our pet measures. But seriously, I think it was the process was structured in such a way, and that this issue of validation was stressed so much and repeatedly, and there was a sort of an ethos in the working group as well. So I say that just in terms of the confidence that I think you can feel when you use these measures. I think you're using state of the art.
Okay, thank you. So there's one more question that I have, and then you also should be receiving a poll soon. So one more question from the chat is maybe something, Paula, you want to address because it's focusing on food insecurity, and it's a question of whether studies of adult health disparities have shown childhood food insecurity to be as important as the current food insecurity, and if the toolkit considered measures of his sort of historical food insecurity, and if that's included or not.
Well, I saw that in the chat and I thought, what a fantastic question. We know that experiences in childhood have lasting effects that don't manifest in measurable disease, often, until later in adulthood. And how many of us have funding for, multi-decade longitudinal studies? Not many. So I think it's a really valid question. The measurement was really about adult food insecurity, and my understanding of the part of the reason for that is that in a situation of food scarcity, that adults will they will give children, they'll do without, and they'll give the available food to children. And so measuring security in children is challenging. So I'm not aware that there's a measure in the toolkit on that. It would be wonderful if there were, and I applaud your thinking about health effects across the life course.
Okay, thanks. So I think that Dr. Shalwa may have a question as well. I know that he sent me one earlier and may want to ask it himself. Otherwise, I can try to summarize it.
Great. Well, again, thank you, Alicia and Paula, for being such a terrific resource on this and your openness to being contacted after this as well. One of the tasks before us is the Coordinating Center, and as the Multiple Chronic Diseases Disparities Research Consortium is choosing, the set of measures. This is more of an opinion question. Some of the panels thinking around collections of instruments, like was there any consensus around the collections of instruments covering multiple domains that were a minimum. One of the things we really haven't done a good job, looking at structural measures and things, but talk to us a little bit about some of the thinking around that. Picking and choosing is probably not the way to go. We really want to come up with a comprehensive set of measures, but one that we can actually do in the field without putting too much of a onerous burden on participants.
Yeah, you probably know.
Please go ahead. Go ahead, Paula.
Well, no, I'm thinking you're better equipped to answer that. I mean, my feeling was that a lot of those considerations took place outside our working group, and that I was thrilled when the working group agreed to adopt a wealth measure. That was a significant expansion, conceptually, on, an incredibly important measure of economic resources. But we weren't really working on a whole, what can I say, on the whole spectrum of measures. I think you know more about that part of the process, Alicia.
I think, thanks, Paula. I think that, Edwin, I would say that there is nothing wrong with picking and choosing. And the reason for that is that these were not designed to be, it really depends on what you're studying. And for those, here in this collaborative where people are really working on disparities in chronic disease, I think that they're really going to want to, there are certain things that they're going to want to for sure cover that are in the core measures, and some things that they may not, or that are in the individual social determinants of health. And then for the structural determinants of health, I do think it may be very useful to look at things like concentrated poverty. And as you know, there's a large literature, there's a substantial literature on race ethnic segregation that may be of interest depending again on what part of the country the group is working in. But I think there's nothing wrong with picking and choosing what are the individual level measures that everyone should include at a minimum, and perhaps a community level measure that, or two that you want everyone to include. I don't think that is problematic from my perspective. We did not think of these as packages because again, this is not necessarily meant for people, even with the expertise of people on this call, who are disparities researchers, very focused on the social determinants of health, but more for, hey, if you're working on whatever, and you want to include one of these variables as a co-founder. Does that help, Edwin?
Very clear, thank you.
Yeah, and I actually have been impressed with the breadth of the structural measures. It was more than I might have expected would have come out of a, pardon me, a federal process.
And then I know that and I wish I could say I do this in all of my studies, and I don't. But I think that it is extremely important for us as equity researchers to think through a little bit of our conceptual model, and that using a DAG or drawing through our conceptual model rather than just well, we kind of need to know this, is so helpful in clarifying what are the non-negotiables. And I think that really in a group like this, where you're working in very different communities with somewhat varying concerns, having that core, the non-negotiable, we're all going to do X is probably, all of this is part of all of our conceptual models, is probably very helpful.
Right. So, okay, with that, we had jammed in a lot of questions. Really appreciate everything. I'm going to hand it back to Dr. Khalili to tie it up for us.
Thank you, Dr. Kensky, for that wonderful job of moderating this session, and Dr. Fernandez and Dr. Braveman for all your wisdom. We've certainly learned a lot. I'd like to also thank our audience for their active participation, and we really look forward to seeing you on our next session. Thank you again.